Please welcome Kindra Clark-Snustad.
Thanks for that introduction, Scott. Kind of make it sound like I didn't think anything else was out there in the world, just the UW DHC. Yeah, thanks for all of you guys for coming too. This is really fantastic to have such a great group of people learning about IBD. So thanks for spending your Saturday here. So yeah, my topic will be kind of a practical approach to health maintenance. Here are my disclosures. So people with inflammatory bowel disease have increased risks due to the disease itself, and a lot of the medications that we utilize can also increase those risks. Luckily, there are a lot of health maintenance preventative measures that you can implement to reduce these risks, but unfortunately, studies have shown that people with IBD seem to receive these measures at lower rates than the general population. The one study suggested only about 28% of IBD patients got regular flu shots, and maybe only about 9% got pneumonia shots. So that's way too low, and I think we can do better than that. Another dynamic is that IBD patients tend to see their GI providers the most. I can tell you that Scott Lee is listed as the primary care provider for a lot of patients, and so it's important that we educate our patients on these issues and also communicate well with the primary care teams to make sure patients are getting what they need. So the objectives of this talk are to identify which patients are at increased risk of infection, skin, cervical, and colorectal cancer, osteoporosis, harm from nicotine use, and mental health concerns like anxiety and depression. And we also want to learn about which preventative care recommendations can help reduce those risks. There's not really one good resource you can look to that covers all of these recommendations, so I've listed a number of organizations that have contributed to these recommendations. So first thing we'll talk about is infection. All patients with IBD are at normal risk for infection and should receive vaccines according to national guidelines. And people who are on immunosuppression are at higher risk, and they should receive additional vaccines. So some of the general recommendations for vaccines include annual flu shot for all patients, Tdap, the MMR vaccine, assuming your patient is not on immunosuppression, meningococcal, hepatitis A and B, and also HPV. Patients, like I said, on immunosuppression are at higher risk of infection, and infections can also be more severe. And for the purposes of these vaccine recommendations, immunosuppression is defined as any patient who's treated with one of the following doses of prednisone, methotrexate, azathioprine 6-MP, biologic agents, or small molecules. And like Scott said, this covers the vast majority of your patients that are receiving treatment beyond mesalamines or diet. All right, so flu season is here. Most people recover from the flu without serious complications, but flu can lead to pneumonia, can lead to hospitalizations or death, and the flu vaccine can be effective. So in the 2017-2018 season, the flu shot was estimated to have prevented 7 million illnesses, and the flu shot that year was only like 38% effective, so this can have a huge impact on your patients. People who are on immunosuppression are at higher risk of infection, and also, many patients will have a post-infectious IBD flare, so this can have a serious quality of life impact on your patients. So do recommend the annual flu shot. The CDC says this can be with inactivated flu vaccines or recombinant flu vaccines. And for your patients who are on immunosuppression, they should avoid the intranasal live vaccine. Okay. Patients with IBD are also at increased risk for bacterial pneumonia, and this is a figure from a paper by Long et al., and it's showing that patients with Crohn's, ulcerative colitis, or either diagnosis all have higher annual risks of pneumonia. Fortunately, we have two very good, effective vaccines against this. The first is the pneumococcal conjugate vaccine, or Prevnar, and the second is the pneumococcal polysaccharide vaccine, or Pneumovax. And one order you can go with this is administer Prevnar first, then at least 8 weeks later, Pneumovax, and a Pneumovax booster at 5 years and also age 65. If you do it in the other direction, you should do the Pneumovax first, and then about a year later, the Prevnar. So shingles is another important consideration for your patients. This is an incredibly common illness in the general population. It's estimated about 1 in 3 people in the general population will be impacted by this. And your patients who are on immunosuppression are at higher risk of this, particularly those who are on tofacitinib, which has about a 5% annual risk of shingles. So it's really important to talk to your patients about vaccination for varicella and also shingles. The varicella vaccine is live, so if your patients are on immunosuppression, you probably shouldn't administer this, but if they're not, you could consider checking a titer and getting them that vaccine if they're not positive. For herpes zoster, the most at-risk population are those patients who are over 50. And in that population group, you can recommend the Zostavax, which is live and shouldn't be given to folks on immunosuppression, or the new recombinant zoster vaccine, Shingles, which is not contraindicated for immunosuppressed patients. So there's been some concern with regard to the response rates for vaccines of patients who are already receiving immunosuppressive medications. And this is shown in this figure. So in this paper by Fiorino et al., the folks on in the control group are people treated with mesalamines, and they had about a 90% response rate to the pneumococcal vaccine. Those patients who were treated with infliximab or combination infliximab and azathioprine had statistically lower rates of response at about 60%. So if possible, it is ideal to vaccinate your patients prior to starting immunosuppression. But as you know, some patients present with pretty severe disease, and they should receive treatment without waiting for vaccines. The one exception and implication for live vaccines is these should not be administered to patients who are on immunosuppression. And you should also wait at least 4 weeks after receiving a live vaccine to start these therapies. I listed some of the common live vaccines. So they include the MMR, varicella, the intranasal flu vaccine, yellow fever, typhoid, Zostavax, and also the rotavirus. All right, one common question that we get is, how about those, the household members of people living with immunosuppressed patients? Can they receive live vaccines? And the answer is generally yes, they can, and there are a few precautions. One is that immunocompromised patients should avoid handling the diapers of infants who have received the live rotavirus vaccine, which no one has complained about. And another one is that immunosuppressed patients should avoid contact with anyone who's gotten a skin lesion after receiving varicella or the zoster vaccine. All right, so we'll switch gears a little bit here and start talking about implications for malignancies. Colorectal cancer is a really important issue and can impact a majority of your patients. Any IBD patient who has involvement of at least 1/3 of their colon for at least 8 years of disease duration, they are at higher risk of colorectal cancer. And some studies have reported this risk to be as high as 18% after 30 years of colitis, which is really high. Some of the more recent studies have suggested this rate is lower, and that's probably due to having more effective medications or having better surveillance techniques, but this is still just a really important issue to talk to your patients about. You should also be able to identify which patients are at higher risk. Those would include patients who have a comorbid diagnosis with primary sclerosing cholangitis, people who are diagnosed at a younger age, have a longer disease duration, more severe inflammation, or a family history of colorectal cancer. So in IBD, most cancers are thought to arise from dysplasia or precancerous findings, and for that reason, surveillance strategies have focused on surveillance colonoscopy to identify any dysplasia and treat it early and appropriately. There are several guidelines who have suggested what is the appropriate interval for patients to receive colonoscopies, and they differ a little bit, but most of them recommend a surveillance colonoscopy every 1 to 3 years, depending on the risk factors of that patient. And most guidelines also agree that people who have PSC should receive annual surveillance colonoscopy starting at the time of PSC diagnosis. All right, so skin cancer is another important issue, and this can impact all IBD patients, and particularly those who are already on immunosuppression. Studies have shown that patients with IBD in general have higher rates of melanoma skin cancer. And luckily, the overall risk is low, but studies have reported that patients with IBD are at about a 37% higher risk of melanoma. And studies are less clear about whether or not the immunosuppression impacts this risk. The studies do more conclusively suggest that non-melanoma skin cancers are more often occur in patients who have current or past history with thiopurines, so azathioprine or 6-MP. Because of these risk factors, the AGA has recommended that all patients receive sun exposure precautions, so wear sunscreen, live in Seattle in the fall and winter, wear protective clothing. And if patients are on immunosuppression, you should consider having them evaluated by a dermatologist to assess their risk, and you could consider annual visual skin exams. Cervical cancer is another issue that can impact patients with inflammatory bowel disease. It's less clear if the increased risk of cervical cancer is linked to the diagnosis itself, but studies have suggested that immunosuppression is associated with higher rates of abnormal pap smears and cervical cancer. Also, cervical cancer arises from chronic infection with HPV. So for these reasons, recommendations are for patients who are on immunosuppression, they should receive an annual cervical pap smear. That should start at age 21. And also, it's important for this reason to talk to your patients about the HPV vaccine to reduce this risk. So bone density is another important issue in patients with IBD. Some studies have reported rates of osteoporosis of about 14 to 40% in IBD patients, and this obviously increases people's risk of fractures. The pathophysiology of low bone density in IBD is complex. It probably has a lot to do with patients' corticosteroid use, but also it's impacted by chronic inflammation, malnutrition, vitamin D, and calcium deficiency. And there are certain groups that are at higher risk. So these would include patients who have steroid use for greater than 3 months, females over the age of 65, males over 70, and anyone with a history of a fragility fracture. So because of these risk factors, the AGA has recommended that if your patients do have one or more of the risk factors, you should consider screening with a DEXA scan at the time of diagnosis and at various intervals afterward. This probably includes the vast majority of your patients. So we haven't talked about biologics and other more effective small molecules yet, but these can be really highly effective medications for your patients, and they are well worth the risk, in my opinion, if they're indicated. But if you do start one of these therapies in a patient who already has an existing infection, that can make that infection worse. And that's the reason why there is this recommendation to screen for tuberculosis, which can be done with a skin test or a blood test, and also screen for hepatitis B with a serology. If your patient is not immune, this is a great opportunity to talk about the hepatitis B vaccination. And if they do have concerns for infection, you should evaluate that and treat or rule out the infection prior to starting. So we all know that smoking is bad for you, but this can be have particular negative effects in patients with Crohn's disease. Several studies have suggested that smokers in these big cohorts are more likely to be actually diagnosed with Crohn's disease, about 2 or 3 times more likely. Also, for people with Crohn's disease who are smoking, several studies have reported negative impacts for their disease course. For example, smokers tend to report more extraintestinal manifestations of disease compared to non-smokers. For smokers who require balloon dilation of a stricture, they seem to require these more frequently. Also, several clinical trials have reported that people who smoke with Crohn's disease have lower rates of response to biologic therapies and also shorter duration of response. So it's really important to talk to your patients about the risks of nicotine use and recommend cessation if that is present. So I think IBD can sometimes be an invisible disease, and the mental health concerns for patients with IBD can also sometimes be invisible. People aren't always going to present and tell you that how they're feeling. So I think screening for mental health concerns is incredibly important. Some of the more conservative reports on the prevalence of anxiety and depression that I've seen are about 20% of your populations will be impacted by this. So I think implementing screening techniques in the clinic can be a really helpful tool, assuming that you are able to refer for treatment. Also, inflammatory bowel disease affects how we take in nutrients. So malnutrition and vitamin deficiencies are really common. And this can be common in people with active and also inactive disease. So it's well worth working with your multidisciplinary team, involving your dietitian to try to improve the nutritional status of your patients. Also, it's probably worth considering screening for specific vitamin deficiencies. People who have had an ileal resection of greater than 30 centimeters are at high risk for vitamin B12 deficiency. And vitamin D, folate, and iron are also commonly low in these populations. So we just went through a number of recommendations. It can be really challenging to talk to your patients about why you're recommending these tests and what you're recommending in a really short clinic visit when you have generally other priorities to discuss. So there are some things you can consider to improve these recommendations for your patients. There are a couple really great checklists out there, like one-pager checklists you can go through and make sure that patients are receiving what they need, and I'll give you some links to those. You could also consider offering vaccines in your GI office. So if you have flu shot or pneumonia shot available right there at the end of your visit, that's going to improve adherence to those. You can implement tracking systems, and also, especially for patients who live far from your site, consider communicating well with your primary care teams to make sure people are getting what they need. So in summary, patients with IBD are at increased risk of infections, skin, cervical, and colorectal cancer, osteoporosis, harm from nicotine use, anxiety and depression, and health maintenance recommendations can help to reduce these risks. So here are some of my favorite checklists. The Crohn's and Colitis Foundation has a really great one-pager for adult patients and also a nice discussion guide for pediatric patients. And Cornerstone's Health has also put together a nice one-page checklist you can use. So thanks for your time.